Gracilis flap for repair of recurrent rectovaginal fistula. Recurrent rectovaginal fistula occurs in about half of primary repairs using the transanal or transvaginal approach, and is associated with decreased blood supply and tissue scarring, and often requires interposition of healthy tissue for successful repair. The patient is a 76-year-old G2P2 female who presented with a recurrent rectovaginal fistula. Primary transvaginal repair with diverting colostomy had been completed by colorectal surgery in the setting of a chronic rectal abscess secondary to diverticulitis. She healed well from her initial surgery. However, 3 months post-operatively, she noted new vaginal discharge, and a bubble test revealed a 2 mm recurrent rectovaginal fistula in the same location as a prior primary repair. Plastic surgery was consulted, and decision was made for secondary repair with Gracilis muscle flap. Gracilis margins were marked by the plastic surgeon. A betadine washout of the rectum is performed, along with normal vaginal prep and chlorhexidine prep of the right thigh. The fistula tract is easily identified using a rectal finger and infiltrated with local anesthetic. Using a transvaginal approach, a sharp circumferential incision is first made around the tract with a margin of about 0.5 centimeter. The tract is excised and the surrounding tissue undermined in the rectovaginal plane until bleeding edges are noted, indicating viability of tissue. Using a rectal finger to elevate the fistula tract, the rectal side of the fistula is closed using a 3/0 delayed absorbable PDS suture in multiple layers. Attention was then turned to the gracilis muscle dissection. The gracilis muscle originates on the body of the pubis and the inferior pubic ramus and inserts on the medial tubercle of the tibia. It is innervated by the obturator nerve, and its action is to medially rotate the leg at the knee joint. The adductor longus muscle overlies the gracilis muscle proximally. To dissect the gracilis muscle, an incision is first made on the proximal medial thigh. The body of the muscle is identified, and a drain placed for ease of identification. A Doppler is used to check blood supply, which is from the deep and medial circumflex femoral arteries. Additional distal incisions are added as needed to clarify anatomy, and may be necessary in a patient with a larger BMI. Care is taken to maintain the neurovascular bundle throughout dissection. A tunnel is then created from the most proximal thigh incision medially using blunt dissection and the aid of a lighted retractor. The diameter of this tunnel must be large enough to prevent compression and necrosis of the muscle flap. A ring forceps is used to pull through a drain for later identification of the tract. Prior to cutting the distal gracilis tendon, continuity of the muscle is triple checked, and the distal end of the muscle is tagged with suture. The gracilis tendon is cut at the junction with the muscle, rotated medially, and pulled through the previously created tunnels and into the most proximal thigh incision. Additional fibrous connections are released to increase flap mobility. A ring forceps is used to gently push the flap through the tract and into the vagina. Here we can see gracilis muscle that has been rotated medially into the pelvis, and its intact blood supply from the medial circumflex femoral artery. The more superficial adductor longus muscle can also be seen. After irrigation, the gracilis muscle body is then secured in place overlying the rectal repair using interrupted 3/0 polyglactin 910 suture. 3 sutures are first placed proximal to the rectal repair in healthy appearing tissue and tagged. After trimming of the gracilis muscle, these sutures are placed through the muscle flap and tied. Three additional sutures are placed distal to the rectal repair, passed through the muscle, and tied. The area is irrigated and the vaginal mucosa is closed with interrupted polyglactin 9-10 sutures. Finally, irrigation, drain placement, and closure of the thigh incisions is completed. The patient did well post-operatively and was discharged on post-operative day 2 with the drain in place. Options for repair of recurrent rectovaginal fistula include interposition of tissue, such as Gracilis muscle and Martius fat pad, as well as various biologic materials. Common complications following Gracilis flap are surgical site infection, as well as temporary functional lower limb problems, both at around 13%. Other rare complications include hematoma, DVT, and hypoesthesia. Gracilis muscle interposition has an overall mean success rate of about 80% for recurrent rectovaginal fistula, with recurrent rates of about 20% at 24 months. We presented a case of recurrent rectovaginal fistula in a complex patient. Gracilis flap is one option to repair these difficult conditions.